Okay, today we're going to talk about medical emergencies and figure out what the difference between medical emergencies and trauma emergencies are. So that's a good place to start. What is the difference between a medical emergency and a traumatic emergency?
Traumatic is resulting of physical forces applied to the body.
Okay, so a trauma is a result of a force applied to the body. What does that mean about medical?
That means it's everything else,
Means it's everything else?
which is to say,
Illnesses.
illness or conditions caused by disease.
Okay, so something that happens within or because of the body. Okay. Why is it important to differentiate between the two?
Treat them pretty differently.
Do you treat them differently?
Well, yeah, your signs and symptoms are all going to be different. In trauma, you can kind of you have a mechanism of injury and you've got a suspicion of injury and all that. So you can see things. Medical are sometimes different because you don't get to see some of the buildup. I would say the timing is different.
Why else might they be different?
A person's reaction.
Okay. Why else? How do your treatment methods differ?
Trauma, a lot of times you're doing the control bleeding, protecting C-spine, those types of things, whereas medical, it's not necessarily the same. Typically you don't have to worry about C-spine as much because unless they fell over, I guess, and it's an old person or something, but
The key
Young people can fall too.
But you don't need to worry about C-spine as much. Traumatic, I guess, like I said, is just, it's more, I don't know, controlling the bleeding and protecting the airway and those types of things, whereas medical isn't as much unless they...
There are a lot more physical interventions that you can do for a trauma patient. That's what we spend a lot of time learning, is those physical interventions. If you think about the 10 skills that we're going to be practicing and testing on, we have trauma assessment, patient assessment and management of a trauma patient assessment and management of a medical patient. So we've got one trauma, one medical. We've got oxygen administration by non-rebreather mask, which could be trauma or medical. We've got bag valve mask ventilation of an apneic adult patient, which could be trauma or medical. We've got cardiac arrest management with AED, which could be trauma or medical. We have spinal mobilization of a supine patient. Where does that fall? Trauma. We've got, now you've got me going with my hashes backwards. We've got, that was 5.
Splinting.
Yeah, that's a random one. I was trying to find the other necessary one. Trauma,
The necessaries
medical,
are
AED, non-rebreather, BVM,
cardiac.
spinal. How did I wind up with that many?
1, 2, 3, 4.
Trauma? Oh, because trauma and medical were each their own. Okay, we're good. We're on the right track. Okay, splinting of a long bone, splinting of a joint, spinal mobilization of a seated patient, and bleeding control and shock management. So the vast majority of the skills that you are given focus on trauma. Right? Which is great. Trauma's cool. Those are fun calls to respond to. What is the vast majority of the calls that a normal EMT responds to?
Sick people.
Medical. Yeah, sick people. Why do I say normal and roll my eyes and not include you guys?
So we're not normal.
You're not normal.
The community.
Yeah, your response area, your response community is not stereotypical, right?
It's no real residential area.
Yeah. Okay, so we spent a lot of time in trauma, and it was a difficult unit for us, right? We're going to cover medical between now and spring break. You guys are going to take your Unit 4 exam at spring break, which is the last week in March. Okay, so I think I see you guys last on the 23rd of March. So that's 3.5 weeks from today. We're going to cover medical. We do chapter 14, 15, 16, 17, 18, 19, 20, and 21.
22 and 23.
22 and 23. There you go. It's a lot of information shoved in a short amount of space. What we need to remember is that, particularly in medical, while there may be a lot of things wrong that you might be able to help your patient with, and we're definitely going to talk about the different tools that you have in your toolbox, in many cases, your best tool and your only tool is to get them in the ambulance and get them on their way to the hospital. Okay? All right. So let's talk about types of medical emergencies, because there are a whole bunch of them. But there's some kind of broad categories. We have respiratory emergencies. What are some examples of respiratory emergencies we might have to deal with?
Asthma.
Asthma is a big one. Okay, we also have cardiovascular emergencies. Give me an example.
Heart attack.
Heart attack. So AMI
Yes.
Or CHF.
or CHF. Yeah, we could have CHF. We talked about CHF and the findings of CHF a little bit, didn't we? When we talked about backing up out of the left side versus backing up out of the right side of the heart and some of the symptoms that go along with that. We'll discuss that back up a little bit more when we get to cardiovascular. Neurologic.
Stroke.
Stroke. Seizure.
It's amazing how many people have seizures these days.
What's that, Chief?
I said it's amazing how many people have seizures these days.
Yeah.
Listen to the scanner and listen to what they're being dispatched on.
Gastrointestinal.
Appendicitis.
Appendicitis. Then we have urologic.
Kidney stones.
Kidney stones. Kidney stones are a big one. They're very painful. Or so I've heard. I've never had them. I better knock on the lid real fast. It's fake.
There's probably wood shavings in there.
Endocrine.
Rest of it.
Diabetes.
Hematologic.
Hemophilia.
Hemophilia. Good call.
I've got a house with 4 kids across the street that all have that.
Immunologic.
2 are really bad, and the other 2 are kind of under control.
Allergic reactions.
Okay, allergic reaction or anaphylaxis. What else? What's the next one?
Toxicologic.
Toxicologic?
Yep.
Why is toxicologic in medical and not in trauma?
It's inside the body. I don't know.
Well, it's poisoning.
Something you put inside, I guess. I don't know.
It's not force upon the body, it's, you've polluted it.
Okay.
It could go either way, I think.
Could also go overdose.
Right. Which is why I'm kind of surprised that it's in medical and not in trauma, because it's not something that, it's really something that's caused by an outside force, right? Although it is caused by the body's response to that introduction of whatever drug it is. So,
And that could
I guess I
include,
can understand.
and that could include alcohol too.
Could include alcohol. Yeah, when we get to toxicologic, we talk about way more than just, just street drugs, or we're trying to find the difference between medicine and drugs, and that's fun. I think we did that already in legal and medical, or medical and legal. So toxicologic is drugs, alcohol, whatever. Okay,
Psychiatric.
psychiatric.
Alzheimer. Depression. I don't like that one. Gynecologic. STDs. Ectopic pregnancy. And others.
Okay, so just looking at these briefly, what is one of the tools that you always have in your toolbox to help a patient in one of these situations?
Oxygen.
Oxygen. We always have oxygen. So in our toolbox, we have O2. What else do we have?
The ability to transport.
Yeah, we have transport. Every single one of these patients, we can transport them to a hospital, right? So in our toolbox for all of them, we have the option to transport. What's another option?
There's different things for different things.
Okay,
Are you
but
talking about
one
general for
tool
everything?
that still covers everything. What'd you say, Dusty?
Is it additional resource?
Additional resources. What are those additional resources?
Advanced life support?
ALS. Yeah. So no matter what medical scenario we go on, no matter what call, doesn't matter what call, we always have these tools in our toolbox. Now, what we need to remember is that even though these tools are always available to us for every single call, they might not always be the most appropriate tool for the job. I'm particularly talking about CHF and oxygen and how that combination can cause a person, not CHF, COPD. Let me put that up there. How the combination of oxygen with COPD can cause a person to actually stop breathing. When we talk about their hypoxic and their carboxic drives, that combination can slow their respiratory rate down. That being said, we're not going to withhold oxygen from someone if we think that they need it. We just need to be ready to support them with manual ventilations.
What does COPD stand for again?
Pardon?
What does COPD stand for again?
Chronic obstructive pulmonary disease. Okay, so when we talk about assessment of a medical patient, it's kind of similar to assessment of a trauma patient, except instead of focusing on their mechanism of injury, we focus on the nature of illness. How do we figure out what's going on with them?
Ask questions.
Ask questions. What kind of questions?
Open-ended questions.
Open-ended questions. We're definitely going to start with open-ended questions, right? Okay, so for our nature of illness, we can use the information that dispatch gave us. We can use the information that we find on our scene size up. We can use the information that is in our general impression. And we can start asking questions. As with any other type of call, who is the best source of information?
The patient.
The patient. That should be a no-brainer, right? The patient is always your best source of information unless, what?
They're not responsive or they're not oriented enough to be able to answer questions.
Right, unless they're not competent. If they're not competent, they're not going to be your best source of information. You might still be able to get information from them, but it's hard to trust that information, and you don't always know how accurate it is, right? Okay, so what are the components of patient assessment? What's the first large phase in patient assessment?
General impression.
Not in primary assessment, in patient assessment as a whole. See and size up. And so we start medical with see and size up. Where do we go from there?
Primary or in scene size up.
Let's go in here. Yeah.
BSI.
Okay, so we've got BSI. Is that the same?
Yeah.
Same as what we already learned, right? Then what?
Scene safety.
Scene safety.
Number of patients.
Additional resources.
C-spine.
This should all look absolutely familiar to you because this isn't any different than what we learned in trauma assessment. Right? Okay, so when we get this information, when we get our information from dispatch, it's going to give us what the possible nature of illness is. Now the thing that you have to remember is that your nature of illness may only be what dispatch thinks is going on. Like any other call, you might show up to something that's completely different than what you think it is. Right? My mom's having difficulty breathing. Okay, great, we'll get somebody there. And the paramedics show up and she's not actually having difficulty breathing. It's a result of her congestive heart failure, so maybe she does have difficulty breathing. But it's not because of the difficulty breathing, it's because her heart's screwed up. Right? Okay, so we have seen size up. Then where do we go? Let's go to the next large phase.
Primary assessment.
Primary. What do we have there?
General impression.
Yeah.
Level of consciousness, level of responsiveness. Chief complaint, life threats, ABCs, transport.
What's the difference with this transport? What's the difference with this transport decision?
Whether you're gonna run hot, if you're gonna run cold.
Well, you're going to have to make that decision with a trauma patient too. But this transport decision isn't based off a calculated GCS, because GCS is used for trauma patients. Okay? This transport decision is based off the information that you've already gathered, so you can make your best guess from this information about what type of complaint your patient has and where you need to take them. If you have a patient who's a stroke patient, they need to go to a different hospital than someone who's a cardiac patient. So from this information that you've gathered here, you should still be able to make a determination about where your patient needs to go. All right, so we made it through our primary assessment. Then what's next?
History.
History. So we learned about sample and OPQRST in our history, right? When we took history and trauma, which is great because guess what? You need to have both of them here as well. Now, when you're talking to your patient about their cardiac problem, and you need to ask for clarifying questions with their cardiac problem, you're going to get information in this history, but you're going to have to follow up. You're going to have to dig in a little deeper. So if you're talking to your patient and they're telling you that they've got chest pain and it's been going on for 4 hours, instead of just taking that at face value, you're going to have to say something like, well, what changed that you called us now? If you've been suffering from chest pain for 4 hours, why did you just call us now? You know? All right, so now you can't sleep. Okay, why did the pain change? Did the severity of the pain change? Did it move somewhere? You're going to have to ask questions that go beyond the sample and the OPQRST, because you got to get a little bit further into what's going on with that patient so you can help make good decisions for them. So after history, we go to
Secondary.
secondary. And we talked about the difference between a full body and a focused assessment. Okay? This is our medical patient. Our medical patient is conscious and alert. What kind of assessment are we going to use for this medical patient?
Focus.
Focused. So if we're going to use a focused assessment, we're going to have to spend time focused on the body part or system that's affected. So if we go back and we look at our respiratory is our first type of medical emergency, what are we going to focus on for that medical emergency?
Lungs.
Yeah, how are we going to do that?
Auscultate.
Auscultate?
Yep, that word.
Yep.
The lung.
Uh-huh.
The breath sounds.
So we're going to auscultate in a couple different fields, right? So we might have to check 4 fields to auscultate the lungs. What else are we going to focus on?
Chest rise and fall. Respiratory rate. Volume.
If we can hear anything,
Yeah.
right?
Sound.
Yeah. So if the patient is suffering from a respiratory problem, we're going to focus our assessment on that respiratory problem. Let's say that they're suffering from a neurologic problem. They're having a stroke. What are we going to focus on?
Their body systems, I guess. Like if they have, I don't know,
Vital signs.
vital signs. If their face is drooping at all, their numb anywheres, their level of consciousness, I guess.
You're also going to want to try to determine in a stroke patient if you have any idea when it actually happened.
That's right.
Because there are things, you have a window of time, you can get them to a hospital that deals with this stuff. They can administer stroke busters. I don't know what they're called. but-
Thrombolytics.
Okay.
Yeah. Hot busters. Yeah. Okay, so depending on what body system is affected or what body system you think is affected, you're going to have to adjust your assessment. If we're dealing with someone who's a stroke patient, we are going to need to focus on the signs and symptoms of their stroke, but we're also going to need to remember that this stroke patient might have a hard time maintaining their own airway. So we need to stay alert for that airway problem as well. All right? And then where do we go from here?
Reassessment.
Reassessment. How often do we reassess?
5 or 15. 5 for unstable.
Okay. Now, somewhere in here, things get changed up a little bit. From right here at our secondary assessment to the bottom of our assessment sheet, we make some changes. Okay? We need to figure out what our patient's vital signs are. And we need to obtain a full set of vital signs. When we obtain that full set of vital signs, why do you think that is?
Can you see trends?
To see trends, so trending is important. What's another reason? Let's talk about our cardiovascular patient. Why would we need to know what our vital signs are for our cardiovascular patient?
To know.
Change.
To see if they change.
To know how it's functioning at that time.
Okay, so again, trending.
If we
Are
gave
there-
if we gave any medication,
Yeah.
like a nitro.
If
see
we give
it's
any
helping,
medication, we need to know what their vital signs are. Why?
see if it's doing any good
To see if it's doing any good
or bad.
Or if we
Or
prevent,
bad.
prevent from hurting them.
or to keep from hurting them. If their blood pressure, their systolic blood pressure is below 100, we don't give nitroglycerin. So you have to make sure that you can take their vital signs before you decide what type of intervention you're going to give them. If you have a cardiac arrest patient who's got a blood pressure of 98/52, you can't give them nitroglycerin. So what's your other option?
Give them to the hospital.
You can take them to the hospital. You could also give them 324 milligrams of baby aspirin, as long as your medical director says it's okay. But in order for you to know what the appropriate intervention is for that patient, you have to get their vital signs, and then you have to be able to make a decision about what that intervention is and how you're going to do it. It's pretty easy to look at a trauma patient and say, hey, that patient has a comminuted fracture of their tib fib. I need to splint that. You can look at that and visibly see that that needs to be splinted. For a medical patient, you have to look at their vital signs and their history and their background and what medications they're on, what medications that they have taken, if they've already done nitroglycerin. You need to look at all of that so that you can decide what the best course of action is for your patient that time. Medical is kind of like playing Sherlock Holmes. You got to try and figure out what's wrong with your patient and how you're going to fix it with what exists in your toolbox. So we're going to take vital signs, then we're going to give any interventions that we can give. Okay? We're going to show how to do our reassessment, and then last but not least, we're going to give a transfer report. The transfer report says who we are, what patient we're carrying, not by name, but by age and what the condition is, their first set of vital signs, any interventions that you gave them, their most recent set of vital signs, and your ETA to the hospital. Okay? Does any of this change your responsibility to your patient? Does it maybe make it a little bit more difficult to figure out what's wrong?
Yeah.
It might. One of the other things that we can add to history is we can add another mnemonic. What color was I using this mnemonic? This one is called tacos. What do you think tacos means?
Delicious.
What?
Delicious.
Delicious, yeah. One of my kids back there said, why tacos? And the other kid said, because we all know that tacos are like drugs, man. Okay, so tacos is tobacco, alcohol, caffeine, OTCs, and sexual or street drugs. Why do we need to ask these questions of our patient?
So you know if they've taken any of these things, it's going to be affecting them, and if you're going to give them something else, like if somebody's taken Viagra, I don't believe you're supposed to give them nitro.
Yeah, why not?
Because they already have increased blood flow and dilated
It'll cause a dangerous drop in
veins
blood
or
pressure.
whatever, yeah.
Why does it cause a dangerous drop in blood pressure? You're on the right track.
The veins are already dilated, and then the nitro is just going to make the blood thinner and
Nitro
Or-
doesn't make the blood thinner.
dilate more, sorry,
Dilates the veins, yeah.
and then makes it even worse, basically.
Yeah. Yeah. They're both vasodilators. We don't need to give a vasodilator on top of a vasodilator. Okay.
What's aspirin do?
Pardon?
What does aspirin do?
Aspirin prevents the aggregation of the platelets. So it kind of makes the blood a little stickier.
Makes it
it
so
stickier?
slippery.
Pardon?
I
I'm
thought it was
sorry, you're
slippery,
right.
so things
More
over.
slippery.
Okay.
Slipperier. There we go. I think that's what I was trying to say. Prevents the aggregation of the platelets, so it keeps it from sticking. Yeah, more slippery. Slipperier. All right. Do you have any questions about the introduction to medical? Your book talks about all sorts of viruses that you can get or that you can be exposed to and kind of how to prevent your exposure. But we don't really need to go into all of that. Any other questions about medical overview? No?